Hello, welcome to AMCI Saturday Study Session, or SSS. I'm Mrs. J, Curriculum Director here at AMCI, and I am delighted to present AMCI Lead Instructor Ms. Tamika, along with her guest. Without further ado, let's get started. Take it away, Ms. Tamika.
Good morning, coders. How are you? Yeah, Geetha. Some mornings are like that. It's more like you feel like you're on the left more so than the right. All dutied up and everything. Good morning, Heather. Hey, Miss Keisha. All right, and I see Miss Carla's in there. Hey, I know you guys are ready to roll, and you guys are looking fabulous. I know you are. I just know you are. We are going to do the digestive and urinary male and female sections. And as usual, we hope to bring you one step closer to coding mastery because you guys are doing a fantastic job. And I know you're going to do some wonderful things today in your SSS session. So I'm going to bring my partner to the floor. You know who she is. Come on, Miss Andrea.
Good morning, coders. Happy Saturday. Thanks so much for joining us. Miss Tamika has an exciting class, and I will see you guys in the chat.
Thank you so much, lady. All right, we're gonna jump on into it. All right, so I know my coders are looking like the side with the Zoom meeting with the video, right? Yeah, I'm glad we don't have video myself. Okay, all right, so we clean, but we not gutsied up. How about that? All right, so again, your study session today is gonna be digestive, urinary, male and female section today. All right, we're going to head on, and you guys know our group study agenda. We've already done those introductions, and we're going to move on into the copyright. We don't have any announcements other than to say, I know you guys are wonderful and you're ready for this study session. Remember your steps for solving that time scenario. Remember the who, what, when, where, how. Remember all of those things, your keyword concepts, your facts to remember, and then we are going to jump into those time scenarios and get rolling. Okay. All right. So our copyright, CPT copyright 2020, American Medical Association, all rights are reserved. CPC is a registered trademark of the AAPC. AAPC content found within this presentation is copyright of AAPC. Keyword concept, FTR, Chun, AMCI Fab 7, Flip, Tap are trademarks of AMCI. All righty, so here we go. Just a brief chun chat with you with digestive system, okay? Try to keep your highlights to a minimum. I know it's difficult because the code families run long and pages at a time, depending on the code family. What you can do is just you can box certain things or highlight very distinct things that help to distinguish one code from another, because if not, you just have a highlighted mess. And all of us have done it before. It's easy to do with digestive, but try as best you can to try to minimize the highlights so that things don't bleed together, if you will. You want to notate brief words at the code level. That will help you too to break the eye up as you move through these codes. You want to consider perhaps a symbol to help differentiate the do not codes. That'll cut down on the use of highlighter. I think you guys know from looking at when I'm explaining different answers that I will put a little red circle with a line through it for do not, and then box whatever that particular thing is. I will box it in red, so that will help break the eye as well instead of using highlighter. Okay. Also carry the parent code over as you move from page to page to allow you to keep up with the code family. So you want to carry over the common code language. If it's a whole lot to the common code language, maybe carry over the first sentence or two of it just to give you a general idea. But if there is indeed room, you want to carry over the entire parent code common language that would apply to the dependent codes that follow. Okay. Your highlighter, it can be whatever choice you choose, Geetha. So really chunning is very it's very, very distinct and depends on the person. we're giving you the concept of chun, the circle, highlight, underline, and notate, and you work within that framework, but you want to really personalize it to what works for you. For me, I use all of those things, the circle, the highlight, the underline, and the notate, but I keep the highlight to a minimum, but that's just my personal preference. And also the notating at the code line, the code level, that's my go-to. I love doing that. I incorporate all four things, but the notating at the code level and boxing certain things as opposed to highlighting, that works for me. But whatever you've started to do in your book, whatever works for you, then that's the right thing to do. All right. Okay, so we're going to get rolling with this digestive system. I know you guys are going to do just fabulous. All right. And the other thing, you know what, like Miss Andrea just said, yes, coders, keep your highlighting color, keep it consistent. Whatever you choose, choose like maybe 2 or 3, but don't start going with the rainbow, because when you see a certain color, you want it to resonate with you that this is something that I should be looking at. Okay, so the object is to make it functional, not necessarily pretty. Okay, so you want it organized and neat, but it should mean something. Be very intentional. All right. Okay, so we are going to start the time scenarios. I'm going to have Miss Andrea come and read us out with the first one. And you guys know how we do it every Saturday. You guys will have 2.5 minutes for each of your scenarios. And I'm going to bring Miss Andrea to the floor.
Okay, coders, we have A 44140, C 18.9, B 44210 with D 49.0, C 44155 with C 19, D 44213 with D 49.0. What are the CPT and ICD-10 CM codes for a hemicolectomy performed on a patient with colon cancer? You got this, coders.
All right, coders, how are we doing? All right, I see some great answers in that chat. If you hadn't got your answer in, go ahead and sneak it in. Yeah, I don't want to spill the beans before you have an opportunity to answer or time to answer. All right, I think we've got everybody, so we're going to go ahead and take a look and unpack this thing. You guys are doing outstanding. And if you just missed it, that's okay. We're going to nudge you into the right direction. Okay, so we are going to take a look at what are our key words with this one. All right. So your answer is indeed A. All right. And many of you got there. And like I said, if you didn't quite get there, we're going to give you that little nudge. So your key words on this one is simply hemicolectomy, and we are coding for a patient with colon cancer. All right. So how could you have eliminated two answers on site? Did anybody take a look at how you could eliminate two of them on site? All right. Yeah, that's right, Geetha. Remember when you do the little, that's right, Soma. That's right, Shabakun, Carla. You guys are spot on. You remember how we associate. That's right, Heather. I see you. I see you, Soma. That's right. Both B and D could have been eliminated on site because they began with the letter D. And we know that the ICD codes that began with C, they are cancer codes. And yeah, Shabakun took it one step further and remembered diabetes. Yeah, so yeah, we could get rid of B and we could get rid of D. All right, so that would eliminate 50% of it. So we're going to go ahead and walk through all of the codes. Okay, so we're coding here for this hemicolectomy. So you guys know how I feel about that med term. It does help you to become a stronger coder, and all of you guys are very strong coders, and knowing your medical terminology, it helps with that. All right, so hemi is half, so the hemicolectomy would mean half or a partial colectomy. Sometimes just knowing those little things will help to steer you in the right direction. Well, right off the 44213, yeah, we know we can't use that because we cannot start this code series with an add-on code. It's going to need something to go with it, so we're going to take that one off. All right, can't be first. You guys know that. All right, so we have 44155. This is indeed a colectomy, but this is coding for a total colectomy, and we've already specified this needs a hemicolectomy code. So we're going to take 44155. That one goes away. Okay. All right, so we head on down here. We are looking here for surgical. This is laparoscopy for 44204. All right. 44202. I'm sorry. And this is your code family here, but this is surgical laparoscopy. All right. But this one here is coding for a total colectomy. All right. And we've already said that no, this needs to be partial. Okay. And it's coding for a laparoscopic procedure as well. Okay. And so unless it says laparoscopic surgical total colectomy, yeah, but no, it's total and we need a partial. So we already know no. All right. So that already just leaves us with A, all right, which is the colectomy partial. All right. And also we know the ICD-10 CM code C18.9, that's for the neoplasm. And you guys already knew on site it had to be one of the two. All right. But this one right here is 44140. Okay. So you guys got there with no issue. And like I said, if you just missed it, I know it was because just not taking a look there at that particular wording there for partial. Okay, so no worries at all. We are ready to roll. All right, so we're gonna keep it moving. All right, and that's the other. Be careful right there. Open. Okay, is for an excision, and laparoscopic is for a scope. Okay, so you want to be aware of that. All right, so if you had narrowed it down to the A and C, okay, the code for the total laparoscopic procedure. I'm sorry, let me go back to that page so you can see which one I'm talking about. Okay, so for this one, for a total colectomy, okay, this is an open procedure and we're coding for something for a scope. So let me just point that out to you guys so you're always aware of that. If it's saying laparoscopic or anything like that, if you look this code up and it's saying total colectomy and it's not telling you it's a laparoscopic procedure, then it's open. Okay, so we wouldn't code that. And also it's total. All right, so just wanted to bring that to your attention. And right here in the parenthetical guidelines, it's also telling you for this same procedure, if it were total, we would need code 44212. All right, so again, pay attention to your parenthetical guidelines as well, because they will help to nudge you in the right direction. Okay, so you guys all got that. So didn't have to explain much of how you got the answer, but just wanted to point out some little things that will carry you along as you code other things. All right, so let's do it, Miss Andrea. These coders are ready. We're gonna buzz along here.
All right, we have A 44960 with 47562, B 47562, C 47562 with 44970 modifier 51, D 47562 with 44970 modifier 59. What CPT codes are reported when a physician makes two separate incisions to perform a laparoscopic appendectomy and laparoscopic cholecystectomy? You got this, coders.
All right, coders, how we doing? I wanted to give everybody an opportunity to get those answers in there. And I see that most of you have gotten it in there. All right, so go ahead and pop it on in there. No worries, no worries. We're gonna go ahead and unpack this particular one, and I see lots of good answers. Okay, and yeah, and I figured that some of you were teetering between the C and the D. Okay, yeah, is oftentimes that that doggone modifier. No worries. All right. So we're going to get you clear. All right. That's the point of being here with us on this Saturday. Okay. So your answer is D. And some of you got there after a little nudge, and then some of you got there straight away. If you were still teetering, or if you got it after the nudge and just not quite sure why, I'm going to help you. Okay. All right. So you guys already knew what to hone in on. The physician is making two separate incisions. They're going to perform a laparoscopic appendectomy, and they're going to perform a laparoscopic cholecystectomy. All right, so you guys knew what to do. All right, so we head here to code 44950. And with this code family, this is an appendectomy. Okay, and then the dependent code is coding for a ruptured appendix with an abscess, generalized peritonitis. We already knew none of that stuff was going on. And also, I want to also bring to your attention, particularly any section of your book that you're coding for, but particularly when you're in the GI section, make sure you are aware of where you are. Are you under codes for a laparoscopic procedure, or are you under codes that are coding for an open procedure? Okay, you know it's open when you see incision and then you see codes listed afterward. Okay, so this particular code is not laparoscopic, it's open. Okay, and also none of this is going to apply. But as soon as you know, I always tell you, as soon as you know that parent is wrong, anything that falls underneath it, that would be wrong as well. So we're taking that one off of the table. All right, and you guys knew that one also because of the code language. All right, so now we have code 47562, and yeah, it's the common code that's in all of them. All right, so the sticking point is gonna be that doggone modifier. So we already know laparoscopic cholecystectomy, yeah, laparoscopic surgical cholecystectomy. Okay, we're good there. All right, but we had a second procedure, and we already know that B didn't code for that. So you could immediately take that one away because we have this, and we've got this laparoscopic appendectomy and the cholecystectomy. So we're getting rid of 47562, okay? Because we need more than that. That's good, but we need a little bit more, all right? So you guys knew that. All right, now here we go. You guys knew this. All right, the issue was that modifier. All right, so for modifier 51, it is for multiple procedures in the same body area. But for modifier 59, this was distinct, and in this case you had two separate incisions. So that's another giveaway. Okay, you had two separate incisions, so this would be coded as two distinct procedures. Okay, also you want to consider you have the appendix in one area and you have the gallbladder. Okay, for cholecystectomy, you have the gallbladder in another. All right, so two separate incisions. All right, so that's why we're going to take that one away, and we're going to go with D. Okay, so does that help to clarify it? Because I want to keep it as succinct as possible. All right. Okay. No, you are not, Geetha. No, you are not. You are going to know the difference. You are going to know the difference. All right. So that's one way that it can give you kind of a little hint. Okay. Keep in mind two separate incisions. So these are two distinct things that are going on. Okay. Oftentimes, if it's considered like the same body area, you'll see the surgeon will be working off of one scope. They'll go in and insert a new something, a new lens or something. But this case, they're telling you two separate incisions. They're going to try to give you some cues in there. Okay. All right. So how's everybody halfway feeling? You might have to let it just simmer a little bit. And oftentimes the 51 and the 59 modifier, it kind of ebbs and flows for most people. Okay. All right. So we're going to keep it moving, because you guys knew what to do. It was just a matter of that modifier. But just take note of it like I know you have, and just take your time with them, okay? All right, so we're gonna head on into this next one because I know y'all love the long ones. Y'all really do. And we're gonna have Miss Andrea come for these wonderful coders, lady. You have the floor.
Okay, we have A 51050 modifier 52, B 51040 modifier 52, C 51040 modifier 53, and D 51102 modifier 53. The patient has significant morbid obesity and her penis has been retracted to help with dissection. The planned procedure is to place a catheter tube to drain the bladder. It is apparent she has quite a bit of scarring from her previous surgeries and also appears to have an old sinus tract just above the symphysis. A midline incision is made following her old scar from just above the symphysis for a length of about 4 to 6 centimeters. The sinus tract was excised as this was also in the midline and carefully dissected down to the level of the fascia. It does not appear to be an actual hernia as there are no ventral contents within it. Again, there is quite a bit of distortion from previous scarring because of the obesity, but staying in the midline, the fascia is incised just above the symphysis of a length of about 2 centimeters. The fat and scar is incised above the fascia more superiorly and with palpation, mesh from a previous hernia repair is felt. This was not palpable prior to the incision because of her body habitus. The mesh was not exposed or entered. It comes down quite close to the symphysis and certainly is too close to place a suprapubic tube. There is concern the mesh may become infected with an SP tube tract right there. Therefore, decision to abort the procedure is made. What CPT code and modifier are reported for this service? You got this, coders.
All right, coders, how are we doing? I'm giving everybody just a few more moments to get those answers in there. I know this one took a little bit of thinking, and I saw you guys teetering between two answers. You guys quickly got it down to two. Okay, if you hadn't got the answer in there, I'm going to give you just a few more seconds so you can go ahead and slide it in there. All right, we're going to go ahead and unpack it. And I always appreciate you guys participating so much because it definitely helps me to know where I need to focus. Okay. Yeah. All right, Geetha. All right, so here we go. We're going to go ahead and we're going to unpack it. All right. So we're going to unpack it and tell you how we got to C. All right. So your key words. How could you have quickly eliminated two of the answers? Did anybody consider, yeah, your modifiers? That's right, Geetha. So there is a difference between reduced services and discontinued procedures. Right here, they decided to abort the procedure. Yeah, that's right, Shabakun. Yeah, that's right, Carla. You guys are on it. Yeah. So thus we would have eliminated A and B, okay? Because we didn't reduce the services, it was aborted. So therefore it was discontinued. All right. So we're going to keep going. We're going to highlight these keywords. So this patient has morbid obesity. They have a pannus. A pannus is where you have excess skin in the abdominal area that lays over like the pubic area. Okay, so I'm giving you the meaning of that so that it paints the picture for you as to why the surgeon is going through all of this and why it became difficult. Okay, so this pannus is being retracted. They have this planned procedure, which is to place a catheter tube to drain the bladder. A midline incision is made. They're going to follow along an old scar. Okay. And this scar is about 4 to 6 centimeters. The sinus tract is excised. The fascia is incised above the symphysis of about to a length of about 2 centimeters. You have the fat scars incised. You have the mesh from a previous hernia repair is felt. All right. And so there's concern that this mesh could become infected. And so that's why they decided to abort the procedure. So all of this stuff is telling you what the procedure is describing what they're doing as they try to get to the area that they need to get to in order to perform this planned procedure of placing this catheter tube to drain the bladder. Okay, so in essence, the patient is overweight and they're palpating and feeling around. They're trying to see what's in this surgical field, and that's when they find this mesh. So they're like, you know what? This mesh is too close. Remember your medical terminology, the suprapubic tube. So we're down in the lower vaginal, the not vaginal area, the lower abdominal area, getting to the genital area. So they're telling you, this is going to be tricky. We probably need to just leave this alone. And so that's what they do. Okay. So when we look though at this code, we have 51040. All right. This is for a cystostomy and a cystotomy with drainage. Okay. Now, you definitely want to take note of the difference between those two codes. All right. So you notice here with cystostomy with the S. Okay. This is a surgery to specifically provide drainage via a tube or catheter. That's what they're wanting to do. Okay. But we also have the code here, the language here for a cystotomy, and that's simply referring to an incision to puncture the bladder. And it's giving you examples. They might be removing a calculi or repairing some tissue there or some reconstruction. This is allowing the surgeon to look inside the bladder. So make sure that you are clear on what is what, okay? One has an S and the other doesn't, and they describe two different things, okay? So we know this is the code. It's coding for either of those things that takes place, okay? But we have this cystostomy with drainage. All right, there we go. We've got placing the tube and draining. All right, that lines up with this, right? Instead of that. So making sure you're aware of what you are coding for. All right, and this here is cystolithotomy. We had already gotten rid of that. That's from A, okay? We did it with the use of the modifiers, but you know, I always show you the code just in case the modifier didn't jump out at you. You want to know that this cystolithotomy, no, that's not what we're coding for, okay? And then we have aspiration of the bladder. All right, we did know aspiration of the bladder, okay, with the insertion of a suprapubic catheter, okay? So that did not happen, all right? So we have the reduced services. You guys already knew that was not what happened because they aborted the procedure. So they discontinued it. All right, so 53 is what is going to apply right here, okay? So do you guys see the difference between these two codes here? 51102, aspiration of the bladder with insertion of the suprapubic catheter. I think what may have gotten you because you see this catheter language. But here, this is a matter of understanding the terminology and what it means. This is talking about a catheter as well. And that's why I zeroed in on the meaning of these two terms. Okay. And so that's why you know that 51040 with that 53 modifier, that is where you need to be. Okay. All right. So how you feeling? Okay. I wanted to spend a little more time with really honing in on the meaning of these words. And as you move along, if you get some practice scenarios when you're studying, and if you're not sure about these, take a look. This is being very forensic because it is the difference of a letter. Then you need to look it up. Okay. That's what I always did. Look it up. And then I would make myself a note because that way, you know, hey, they're talking about, you know, providing a catheter and drainage as well. Okay. And so even though they didn't do the procedure, it was aborted, but that was the planned procedure. And that's why you code for it. Okay. So somebody might need that little tip right there as well. Okay. All right. So if you need to grab a screenshot, you may, and then we're going to keep it moving because we've got lots of coding scenarios for you wonderful coders. All right, Miss Andrea, I'm advancing my screen and you will have the floor, lady. There you go.
Okay, we have A 49561, K 40.90, B 49566 with K 43.0, C 49566, 49568 with K 43.0, and D 49561 with 49568 and K 43.1. A 42-year-old patient is brought to the operating room for a repair of a recurrent incarcerated incisional hernia using mesh. What CPT and ICD-10 CM codes are reported? You got this, coders.
All right, coders, I'm seeing some terrific, terrific coding in there. I'm loving what I'm seeing. All right. And so if you didn't quite get there, no worries. We're going to give you that nudge. Okay. And this one right here, I'm going to give you something to add in your code book, and you will never miss one of these again. All right. All right. So here we go. Your answer is C. Okay. And like I said, if you didn't get there, we got you. All right. So let's go ahead and unpack it and get to some of these keywords. So this patient is 42 years old. They're coming in for a repair of a recurrent incarcerated incisional hernia using mesh. Okay. All righty. Here we go. All right. So we've got 49560. Okay. That's our parent code. And you guys we're rolling along with that. All right. So we've got, though, this is a recurrent. All right. This is for an initial repair. All right. So this is coding for an initial repair, incarcerated or strangulated. Okay, so we already know that if that parent is wrong, like I always tell you, then anything that falls underneath, because this common code language, and I always specify that if this common code language that comes before the semicolon is incorrect, anything beneath it will be incorrect as well. So code 49561, yeah, we've got to take that one off, because this isn't an initial hernia operation. This is for a recurrent procedure. So that one's gone. All right. And then that one is too. You guys know I'd love to get it to 50-50. So now we can really hone in on these last two here, B and C. So 49565, this is our parent code, and it is for repair of a recurrent incisional or ventral hernia reducible. Okay, but this one here, okay, we need incarcerated or strangulated. Okay, this is reducible, but the one we're coding for is indeed incarcerated or strangulated. All right, so we've got incisional, that's matching up. Yeah, that's what we need. Now, here's your coding tip here. With the exception of the incisional hernia repairs, we need to see these codes here in this right here. And it's nice, they're right together. Okay, we have to see with these codes, the use of a mesh or other prosthesis is not reported separately. Okay, so with this one, okay, mesh isn't bundled into that code. And they're telling us that a mesh is used. Okay. So we have to report it separately. So here we have code 49568. That's for the implantation of a mesh or other prosthesis, okay, for open incisional or ventral hernia repair or mesh closure. And this is incisional. Yeah, and we are coding for a repair. And then it's telling you which codes to use it in combination with or in conjunction with. And there's our code series. And 49566, it fits the bill. So it's giving us several little markers. This one here is missing the mesh. Okay, but this one is coding forward. And you know, this is for completeness sake. Like I told you, stay out of that ICD-10 code book unless you need to. Okay, so we've got the incisional hernia, and here we've got the mesh. I think the wording here is a little confusing, so I'm going to tell you what I did in my book. If you haven't done it already, boom, just make you a little thing, or you can do something, do a little squiggly box, and put yourself a note to add this add-on code 49568. The add-on code is needed because the mesh is not bundled in any of these four procedures. Okay. All right. So does that help? Yeah, yeah. That's right, Keitha. Yeah. Because this right here, every time I read it, it didn't mean that to me, at least not in my head. So I had to put this in my book. Once you put this, whenever you see these codes, and if you're reading that scenario and it's saying they're using a mesh, then you already know you're going to need these codes, and you should see this secondary code. Okay, so you gotta have it. All right. So does that help clear everybody? that was like, oh man. Hey, and no worries. That is all right. If you're like, dang it, that's why you're here. If I see some got it, some ahas, that is indeed why you're making the investment of being here on Saturday. All right. So grab your screenshot if you need it. And even if you got it right, if you want to use this notation so that you know that you get it right next time as well, and even quicker, put that right there and you're good as gold. All right. All right. So we're gonna keep it moving. I'm gonna have Miss Andrea come to the floor, and then you guys know the drill. You have 2.5 minutes from there. All right, lady, you got it.
Okay, coders, we have A 43754 with R40.20 and T42.71XA. B 43753 with T42.4X1A and R40.20. C 43756 with T42.71XA and D 43755 with T43.501A. A 4-year-old patient who accidentally ingests Valium found in his mother's purse is found unconscious and rushed to the ED. The child is treated by the ED physician who inserted a tube orally into the stomach and performed a gastric lavage, removing the stomach contents. What CPT and ICD-10 CM codes are reported? You got this, coders.
All right, coders, how are we feeling? I think I see most of you have gotten answers in there. If you hadn't quite gotten an answer in there, go ahead and slide it in the chat before I spill the beans. You know, I like to give everybody an opportunity to take a go at it, okay? All right. So is everybody good? All right, I'm gonna spill the beans. I'm gonna go ahead and spill the beans, okay? All right, so this particular one, you guys got there, and some of you, if you just missed it, hey, no worries. You know, we always tell you we got you, and that is indeed why you are here. All right, so here are our key words, but first, our answer is B. All right, so I'm gonna tell you how we got there. That's right. I know one of your classmates is going, no. That's all right. Look, I had many of those moments as a student myself, like, what? I was spot on. All right. I'm going to get you there. If you didn't quite get there, like I said, this patient is 4 years old. They've accidentally ingested some Valium, and the ED physician is going to place a tube orally into the stomach, and they're going to perform gastric lavage and remove the stomach contents. Okay. All right. So, how do we get there? We're going to take a look at first, we have code 43754. All right, and this is for gastric intubation and aspiration, diagnostic. All right, this procedure is therapeutic, not diagnostic. Okay, all right, so we're going to take that one off. All right, 43754. All right, now the next one we have here, again, you know that if this common code language for this parent is incorrect, then you know the dependents that fall under it are incorrect as well. So once you see this one, they gave you one. Once you knew that was wrong, that one is too. All right. It is okay. It is okay, Susan. All right. So now we have these last two right here. All right. So let's hone in on them. We've got 43756. This is for a duodenal intubation and aspiration diagnostic. First off, this one right here, we're in the wrong place. Okay. Always be aware of where you are, who, what, when, where. Where are we? This is gastric. Okay. And we need it to be gastric. There, it tells you right there. And it's telling you stomach, gastric. Okay. Even though these are wrong, but they're in the right place. Okay. Just wrong procedure. But this is saying duodenal intubation. So they're in the wrong location. And so that's why C is incorrect. Okay. It's gastric. It's not duodenal or diagnostic. This is for a gastric procedure. This is for a gastric procedure. This is coding for duodenal and for a diagnostic procedure. We are looking for something that is therapeutic. All right. So they've inserted this tube. Yeah, look at there at 43753. We have gastric intubation and aspiration or aspirations, therapeutic, and including lavage if performed. Yeah, it's going to necessitate this physician skill, gastric lavage, removing contents, okay, stomach contents. Yeah, all of those keywords match. Okay, so that's why 43753 is correct. And you know I've got to give you a little, I'm going to always give you a little nugget to hang on to so that it's clear. What is the difference between therapeutic and diagnostic? Okay, because you guys know my brain just works that way. I want to know, like, okay, you talking about therapeutic and diagnostic. What is that? Therapeutic. A therapeutic procedure is any medical or surgical procedure that's performed in order to repair, remove, or otherwise heal any previously determined health concern. We are removing stomach contents. Okay, a diagnostic procedure is an examination to identify something. You're diagnosing something. Okay, I'm looking in the stomach to see if maybe there are some gastric ulcers. I'm diagnosing something there. Okay, so that one would be to identify specific areas of weakness and strength in order to determine a condition, a disease, or illness. Okay, but this is a therapeutic procedure. All right, we need to repair, remove, or otherwise heal something that was previously determined to be a health concern. And in this case, this little guy or little girl accidentally had ingested some Valium. So we've got to take care of that and get those contents out of that little baby's stomach. Okay, that's a baby at 4 in my eyes. All right, so yes, that is the difference. Okay, so if anybody needs to take a screenshot of this one, go ahead and grab it. All right, and then we are going to go ahead and move on to the next one. I hope that made it just a bit clearer, because if you get some like this, like I tell you guys, don't leave anything on that table. All right, I can't wait to see that CPC A after your names. And there we go. Highlighting there, this indeed was therapeutic. Okay, and all these others were diagnostic. All right, so those are the little things too when you are chunning. Let me bring that to your attention. Little things like this. And that's why I said, however you have it in your book, that's what's going to work for you. Okay, but just be aware that some words are pivotal, like I tell you, to the code selection. So you want to be sure to bring that to your attention, either writing it on the side. This is therapeutic, that's diagnostic, so that it'll help you in your code selection as well. All right, so we're going to keep on moving. All right, and it's still going in. We're talking about these last two codes. Okay, so accidentally ingesting, we are going through the ICD-10 codes just for completeness sake. All right, and so it's gonna take you here. We're gonna continue on because we need 7 characters. We know we've got 6, so that tells us the 7th character needs to be A. And it's telling us poisoning by benzodiazepines, accidental, unintentional, and it was unintentional, and that's how we get that one. And then for the patient being unconscious, all right, we're gonna get here to this code group of R40.2 for coma, but we know we need 5 digits, so we need to come down here and do just a little bit more. And so we have unspecified coma or unconsciousness, and that's indeed what was going on. This little person was unconscious, so that's why code R40.20 is our code in the ICD-10 book, and that's how we got to be. But like I told you guys, on that exam, once you get your answer in that CPT manual, and that's enough to determine where you need to be, you code it and you keep going. Okay, bubble that thing in and go on. Okay, all right. So in this case, Geetha, I'll answer that one. Just remind me, and I will answer it and get back with you on that as far as the sequencing is concerned with these. All right, because I want you guys, like I said, to stay in the CPT manual. So I'm not gonna start delving all into that. We're gonna keep on going with this one. But if you want further explanation on it, remind me, and then I'll send it to you. Okay, no worries. All right, so we're gonna keep on rolling. I am going to have Miss Andrea come and read us out.
Okay, we have A 49000 modifier 58, B 49000 modifier 77, C 49402 modifier 77, and D 49402 modifier 78. Margaret has a cholecystoenterostomy with a Roux-en-Y. 5 hours later, she has an enormous amount of pain, abdominal swelling, and a spike in her temperature. She is returned to the OR for an exploratory laparotomy and subsequent removal of a sponge that remained behind from surgery earlier that day. The area had become inflamed and was demonstrating early signs of peritonitis. What is the correct coding for the subsequent services on this date of service? The same surgeon took her back to the OR as the one who performed the original operation. What CPT code is reported? You got this, coders.
All right, coders, how we doing? Did everybody get that answer in there? I want to be sure that everybody has an opportunity to put their answers in here. You guys did outstanding on this scenario. So, hey, I don't have to do much on this one, okay? So we're just going to buzz on through it, and you guys already knew it was D, okay? So, yeah, this patient had this cholecystic cholecystoenterostomy with a Roux-en-Y. And they also had to return to that OR for an exploratory laparotomy and subsequent removal of that sponge that was left behind earlier that day. Subsequent services were performed on the date of service. So how do we code that? And this is the same surgeon as the one who performed the original operation. So believe that you guys were able to solve this scenario without looking up the code or close to it. Okay, so we could do it all just simply looking at the modifiers. That is true, Keith. It does sound like French, doesn't it? Roux and Y. Okay, so yeah, 58. That's for a staged or modified procedure. And we know that no, that wasn't, that was not staged. And 77 is a repeat procedure by another physician. Well, it's the same surgeon. And also, this was unplanned. Okay. All right. And then we would have been left with D. Okay, so that's how you could have solved it right on site with simply those modifiers. I know you wonder why I stress those modifiers, but it's because I want you to be comfortable with them because it could shave some time off. Even if you can't do the whole thing on site like that, it will save you some time, okay? And I'm gonna let you in on something. When I was studying for that exam, I did not like modifiers. I was always like, please, Miss Tracy, please, not the modifiers, man, not the modifiers. Okay, so we're going to be coding here for this subsequent service, okay? Because what's the correct coding for the subsequent service, okay? We're not coding for the original thing that she went in for. She went in for the cholecystoenterostomy with the Roux-en-Y, okay? But we are coding for the subsequent service because she had to return for an exploratory laparotomy, meaning they had to make an incision and then go in there and they're searching for this sponge. All right, so exploratory laparotomy, exploratory chelotomy with or without biopsies. No, we didn't have all that going on. They were doing okay till they started into that. All right, so all of that didn't happen. So we could take that off right there. All right, we're looking at the codes. You know, I'm always going to tell you what the codes read. Okay, we can't just do the modifiers. You need to know about these codes. All right, we have the subsequent removal of this sponge. Removal of peritoneal foreign body from peritoneal cavity. Well, you know what? That's exactly what happened. Yeah, so that's why we're there. All right. And then it was a matter now of just being clear about these modifiers. Repeat procedure by another physician. Okay, this is the same surgeon. All right. And it's wrong too because it's not just a repeat procedure, it is an unplanned procedure and it is by the same physician. Okay. And so that is why D was your answer. Okay. Yeah. All right. So I think you guys were already there. And like I said, if it was a little unclear, but you were just like, which one? I hope now that gives you a little bit more clarity on it. Okay. We're going to keep moving because, like I said, you guys are doing outstanding. I'm going to have Miss Andrea come. You have the floor, lady.
Okay, coders, we have A 42220 modifier 52, Q 35.7, R 56.9, B 42220 modifier 53, Q 35.9 with R 56.9, C 42215 modifier 53, Q 35.9 with R 56.9, and D 42215 modifier 76 with Q 35.7 and R 56.9. An 11-year-old patient is seen in the OR for a secondary palatoplasty for complete unilateral cleft palate. Shortly after general anesthesia is administered, the patient begins to seize. The surgeon quickly terminates the surgery in order to stabilize the patient. What CPT and ICD-10 CM codes are reported for the surgeon? You got this, coders.
All right, coders, I saw some good answers in that chat, and I saw some teetering between two answers. And you guys got there, though. You certainly did. That's what I want to see. Yeah, those modifiers, those modifiers. All right, so your answer is B. All right. And so we're going to go through it. All right. And many of you got there and were like, yeah, okay, I see it now. Yeah. Okay. So we have this 11-year-old patient. They're coming in for a secondary palatoplasty for complete unilateral cleft palate. All right. And so shortly after the anesthesia was administered, the patient begins to seize. And so they terminate the surgery. All right. And they do it rather quickly and rightly so. All right. Yeah, so we have for 42215, all right, we have a palatoplasty, all right, but this is for a major revision, okay? So this is good, but what we need is for a secondary procedure, okay? No mention about a major revision, all right? So we have code 42215, 42215 for C and D, and we can go ahead and take those off, all right? Yeah, that's okay, Miss Carla. All right, so we're gonna take it on down here, and here we go. Yes, secondary lengthening procedure. All right. So we know that these two are okay, but what about these modifiers? That 52 is for reduced services, is for partially reduced or eliminated. Okay. So under these circumstances, it means that that for whatever reason, because of certain circumstances, they reduced some part of the service, okay? But the procedure wasn't reduced. It was discontinued. And also, you want to remember that 52 is a reduction of services by choice, okay, rather than necessity. This was discontinued out of necessity. Okay. The physician or the other qualified health professional, they have elected to terminate it due to extenuating circumstances or those that threaten the well-being of the patient. And certainly a patient who has undergone anesthesia and is seizing, you would have to discontinue it because it is a threat to the well-being of the patient. All right. So this is simply coding for the cleft palate, all right? So we know it's a cleft palate, okay? And so it's going to take us here after we've naturally gone to the alphabetic index, but we are at Q35, and it's Q35.9 because it's unspecified. It just tells us it is a cleft palate, all right? And then for the, there we go, there. Bring you over here to this page, all right? So this is how we got, wait a minute, let me go back before I go into that. Okay, so here. So the cleft palate is how we got the Q35.9. All right, so that's how we got there. And I have the other one on the other page, but this is where I'm getting you to, because like I said, these codes here, they're going to be secondary for you unless you need to break a tie. And in this case, you didn't. Okay, so code 422 42220 with a 53 modifier is what you need. All right. So I want you to definitely hone in on the fact that this 52 modifier, when you have reduced or partially reduced or eliminated certain parts of a procedure, is at the discretion of the physician, but this is by choice. This is out of necessity. Okay. So I hope that that helps to clarify modifiers 52 and 53 for you. All right. And this one here, you know, the 42215, this was for major revision. Okay, so the common language was fine, but we needed specifically this. Okay. All right, so then we're going to go on to the next one that I had here. All right, so a second look starting with these modifiers. All right, so we had 52 and 53. All right, so I already explained to you guys why it wouldn't be 52 and it wouldn't be 76. Okay, that would be a repeat procedure by the same procedure, but we weren't repeating anything. We were discontinuing the procedure. Okay, so you could have done it that way, and then you arrived here. All right, knowing that that's not quite it, and that would have taken you to B as well. All right. Okay. So I think everybody's good with that. Hopefully walking away with a little more clarity with some modifiers will help you as well. All right. So I'm going to move on to the next one. Okay. I know nobody wants to see this one. Hold on. Let me, because we're not going to do that one actually, because I'm looking at the clock. We've got to sneak some urinary stuff in here, okay? So that's exactly what we're going to do. All right, so we are ready to roll. Miss Andrea, you have the floor.
I can't see your scenario yet.
There it is.
Thank
When I
you.
looked up there, I thought I better advance that screen. All right, coders, we're ready.
All right, we have A 54400, B 54416, C 54408, and D 54401. Patient is status post radical retropubic prostatectomy with erectile dysfunction, presenting for penile implant. An inflatable penile prosthesis is inserted. What CPT code is reported for this service? And you got this, coders.
All right, coders. I think most of you have gotten those answers in there. All right. And you guys have done amazing. I tell you what, I'm about to pull out my tissue box because I'm just thrilled. I'm about to shed some tears, y'all. Tears of joy. I love it. Yeah, D is indeed the answer. All right. Okay. So we are going to go ahead and unpack it real quick because I've got yet some more scenarios to get to that are in your urinary male and female section. Okay. So this patient is coming in for an inflatable penile prosthesis that's inserted. You guys were spot on with it. You guys immediately knew. We're going to go ahead and look at this code family here, 54400, insertion of penile prosthesis. Okay, this is coding for one that is non-inflatable. All right, and this one is inflatable. And so that would get rid of that one. All right, well, what about code 54401? Well, that was inflatable, okay, self-contained. So we're going to just give it a light yes here because we need to check out the others. All right, so code 54408, repair of component or components of multi-component. All of these things, as soon as we hit the word repair, we're not repairing it, we're inserting this prosthesis. And so we're going to take code 54408 off. And then we have the remaining code 54416 is removal and replacement. It is for a non-inflatable or inflatable, but we're not removing and replacing anything. They are just having this prosthesis inserted. And so 54416 is no good. And indeed, we're going to give it a firm yes for code 54401. Okay, so that was some good coding on you guys' part. All right, so very, very good. And we're going to keep it moving because I want to get to some additional ones. I had that long one that I showed you guys was for the section that we were in, and we've got to continue moving on because I've got to get some urinary male and female stuff in here. All right, so here we go. All right, Miss Andrea, I know you guys love the long ones. Y'all love them. All right, here we go, lady.
Okay, we have A 52648 with 52204, B 52647, C 52649, and 52224 with modifier 59, 52648 with 52224 modifier 59. Preoperative diagnosis is cytologic atypia and gross hematuria. Postoperative diagnosis, cytologic atypia and gross hematuria. Procedure performed is cystoscopy and random bladder biopsies and green light laser ablation of the prostate. Bladder biopsies were taken of the dome, posterior bladder wall, and lateral side walls. Bug-B was used to fulgurate the biopsy sites to diminish bleeding. Cystoscope was replaced with the cystoscope designed for the green light laser. We introduced this into the patient's urethra and performed green light laser ablation of the prostate down to the level of verumontanum on the prostatic crest near the wall of the urethra. There were some calcifications at the left apex of the prostate, causing damage to the laser, but adequate vaporization was achieved. What CPT codes are reported for this service? You got this, coders.
All right, coders, how we doing? You know I hated to interrupt you guys. I don't see really any answers in there. I know y'all are working hard on this one, and it is okay. All right, you can give me what you think it is. Okay, and then we're gonna go ahead and break it down like we always do. I'm gonna do my very best to make this thing speak to you. Okay, so if you're still getting it in there, get it in there. All right, gonna give you guys 1 second. All right, we're gonna go ahead and unpack it, okay? I see I had a little bit of everything and it's okay. All right, so the answer is D. And some of you were like, I think it's D, I'm not sure. And some of you are just like, look, I don't know. And that's okay, but you're gonna know. You're gonna know. So here we have this patient. Remember, whenever you see first off, preoperative and a postoperative diagnosis, you're gonna always go with the postoperative diagnosis. And these two are the same, but just remember that. Sometimes you have a preoperative diagnosis, but you don't have a definitive diagnosis until after the procedure. So that's why you always go with the postoperative diagnosis. In this case, it is a cytologic atypia and gross hematuria. Like I said, it's the same for both, but that's just a little tidbit for you. The procedure performed is the cystoscopy and random bladder biopsies and green light laser ablation of the prostate. The description of the procedure is that we have bladder biopsies taken of the dome, the posterior bladder wall, and the lateral side walls. The Bugbee was used to fulgurate the biopsy sites. The cystoscope was replaced with a cystoscope and designed for the green light laser. Okay, and then we introduce this into the patient's urethra. We perform the green light laser ablation of the prostate. Okay, and and then we have this going on all the way down to the urethra. Okay, we have some calcifications also of the left apex of the prostate, and then we had some damage that was caused to the laser, but adequate vaporization was achieved. So a lot of things were going on during this procedure, but basically what we're doing is we're going in there with the cystoscope and we're taking some biopsies and we're also using a laser to ablate some ablation of the prostate. We're gonna do some ablation while we're in there. Okay, so we're gonna describe it and tell you what's happening. All right, so let's jump into it here. We have 52647. This is for laser coagulation of the prostate. We have laser, but we were using laser vaporization. Okay, so we're using laser vaporization to take care of the calcifications. There's some calcifications going on with the prostate, so they're using the laser to vaporize these calcifications. This is saying laser coagulation, but that's not what was happening. We had vaporization going on. So 52647, that's no good. All right. So we take a look at code 52648, laser vaporization of the prostate. Yeah, yeah, right there. Laser vaporization, including control of postoperative bleeding, and they have a lot of things going on with this thing that this code will address. Okay, so and we look here. Okay, we've got the cystoscope. All right, so and we also have the green light laser ablation. All of these things, that's good stuff there. If we take a look at code 42648, we have that here and here. All right, so we're going to go ahead and give that a go. What about 42649? This is laser enucleation of the prostate. All right, there's no mention of that. Okay, no mention of that. All right, so we're going to take that one off the board. Now, we've gotten down to this part. So what about these remaining codes, 52204 and 52224? Okay, so 52204, this is for cystourethropy with biopsies. Okay, that looks good, but if you take a look at this one, 52224, cystourethropy, yeah, we had biopsies going on, but we also had fulguration. With fulguration, including cryosurgery or laser surgery, okay, or treatment of minor lesions with or without biopsy. So we had fulguration going on. We also took care of the biopsies as well. So yeah, this was going on, but this is more complete. And remember, we always code to provider what? Certainty and specificity. All right, this is a more complete code. Yeah, we've got the fulguration going on. We've got all of it. We've got the biopsies going on. Okay. So yeah, that's a more complete code. And we have the modifier 59 because these things are distinct procedures that are going on. We do have the vaporization going on, but we also have the distinct procedure going on of the fulguration going on, as well as these biopsies. And you'll agree that those are distinct procedures that are going on in addition to this vaporization. Okay, so does that help clarify it just a little bit? I know a lot was going on, but again, even with how long it is, again, hone in on the keywords. And the one thing that I would do is start going back and forth with the codes. Once you see what's not here, then focus on what is there and start honing in on, okay, what exactly is it saying? Sometimes you got to take the keywords and you got to compare it to the codes that you're given and just go back and forth and kind of do an inventory. The other thing that I would suggest that you do with your chunning is you put coagulation, vaporization, enucleation, like that. So that will force you to take a closer look. You're not trying to rewrite everything when you notate something at the code level, but you're trying to zero in on certain words that I always say are pivotal to the code selection, and it'll cause you to take a second look so you can be even more forensic. Okay. All right, guys, if you need to take a screenshot, go ahead. And we're going to keep on moving because I'm looking at that time. I'm looking at that time and I want to squeeze in at least two more. All right, Miss Andrea, you have the floor for these wonderful coders.
All right, we have A 54150, B 54160, C 54150, modifier 52, and D 54160, modifier 52. A clamp circumcision is performed without dorsal block on a newborn. What CPT code is reported for this service? You got this, coders.
All right, coders, I think most of you have gotten that answer in there. If you haven't, go ahead and slide it in the chat, because if most of you are finished, we're going to keep on going. And I think most of you are, because I want to squeeze that other question in here as well. All right, so we have this clamp circumcision. All right, and the answer is C. And many of you got there. Some of you teetered just a little bit, but that's okay. All right, so it's a clamp circumcision without a dorsal block on a newborn. All right, so most of you were here, A and C. And it's either one of those things you have it one day. And for me, when I was learning it, some days it was crystal and other days not so much. And I don't know why I went back and forth. All right. But I'm going to tell you how I have been able to keep it straight in my head. All right. So circumcision using a clamp or other device with regional dorsal penile or ring block. All right. So we're good there. We know that we've used a clamp for a circumcision. That's not the issue, okay? The issue becomes that modifier, when and when not to use it, okay? So we do not report modifier 63 in conjunction with this code, so we don't have that anyway, all right? So this is talking about the weight of the infant. That's not the issue, okay? The 52 is the sticking point for most people. We're going to report modifier 52 when performed without a dorsal penile or ring block. All right. So this is performed without a dorsal block. So that lets us know that we are going to need modifier 52. Okay. And for code 54146, this here. Okay. So we're taking it there. All right. For code 54160, circumcision surgical, okay, other than a clamp. All right. This is when you perform the circumcision and you're using a surgical excision to do it. So we're using something other than a clamp. So that is why B and D is not there. Okay. So modifier 52, okay, that's when we use it when we have no anesthesia used with it, okay? And you could see why it would be reduced services, because it's the same procedure, but we're not using the anesthesia. And that is what the regional dorsal penile or ring block is. It is a type of anesthesia that's administered to the penile area. You can see, I was trying to find one that was a little more concise to compare the two, but literally, if it is a regional dorsal, if it's a ring block, they literally will take the needle and go around like the base of the penis to numb the nerves that are going into the penis, because imagine you are using a clamp to circumcise the patient. Okay, so a little chun chat, remember the dorsal penile or ring block is anesthesia. Okay, so this one here is talking about the clamp. All right, and this right here is talking about the type of anesthesia. And if no anesthesia is used, that's when you need the 52 modifier. Okay, and this one here, code 54160, this is indeed a circumcision, but it's an excision, it's surgical. Okay. All right. So does that, I think most of you got it. For those of you who were teetering on it, I hope that makes it clear. Okay. And for those of you who have been clear, I hope it keeps you clear. Okay. All right. So, so which one, Soma? This which one do you want me to explain? Is it this, what the ring block is? Okay, let's see. Okay, so the dorsal penile or the ring block, they're just two different types of anesthesia. Okay, they're two different types of anesthesia. So that's the only thing you just need to know. Okay, the regional dorsal penile or ring block, they're just two different types of anesthesia. So if they've gotten anesthesia, this code covers you for both, and this modifier is just clarifying whether or not they had either or. Okay, so don't worry about are they the same? Because it's two different ways of giving the anesthesia is what it is, okay? But they're two different types of anesthesia, but you don't have to pick it apart in that way. If they've been given the dorsal block or the dorsal penile block or the ring block, then you know they've had anesthesia. If this 52 has been added, they have not had anesthesia, okay? And then that way you'll be clear, okay? So there are two types of anesthesia. They're administered different ways in order for you to get the numbness that you need in that area for the procedure. Okay, all right, we're gonna scoot on to this next one. All right, and you guys didn't need all this either. All right, so here we go. All righty, Miss Andrea, you got the floor.
All right, we have A 51726, B 51726 with 51728 modifier 51, 51797, C 51728, 51797, and 51741 with modifier 51. D 51728 modifier 26 with 51797 modifier 26 and 51741 modifiers 51 and 26. The patient presents to the office for cystometrogram. Complex CMG with voiding pressure studies is done. Intra-abdominal voiding pressure studies and complex uroflowmetry are also performed. What CPT codes are reported for this service? You got this, coders.
All right, coders, how we doing? All right, if you hadn't got that answer in there, go ahead and slide it on in there so we can unpack it, okay? And you guys are getting there. For some of you that needed a little nudge, hey, you got there, and that's what I like to see. All right, so I'm going to help you with the nudge all right, before you get the correction, okay? So you'll be clear. No worries there. So here we go. You guys were teetering, most of you, between that C and D, okay? Some of you were not sure about B, and that's okay. So here are keywords. The patient is here at the office, and they're coming in for a cystometrogram or CMG. They had a complex CMG with voiding pressure. They also had an intra-abdominal voiding pressure study and a complex urofluorometry. All right, so all of these things were performed, and your answer is C. How did we get there? Let's take a look. All right, so we have code 51726. It's for a complex cystometrogram. All right, so we've got that going on. That's a good start, but we're going to need more of a description of what is going on. Okay, so for 51726, okay, good start, but we had a whole lot of procedures going on, so there's not enough going on. All right, so we're going to keep it moving, but we're going to continue on with this code family because this common code language here is very, very good. All right, so we're going to keep going. All right, and we're going to take this off as well. Yeah, already, because this is all that 51726 says. Okay, complex cystometrogram. We know that's what's going on, but we had a complex CMG with voiding pressure. There, look at that. There's the sticking point right there. Remember, we want to code to provider certainty and specificity. Yeah, voiding pressure study. So we've got the CMG or the cystometrogram, but we've got it with voiding pressure studies as well. That's why we got to take the 51728. Okay, now this procedure was performed in the office. And because it was performed in the office, you don't need the modifier 26, because 26 would just be for the what? The professional services. And this is performed in the provider's office, so they own the equipment and everything. And so we don't need the 26. Okay, they're not just coming in to read their own voiding pressure studies. They're performing it in everything. All right, so that's why we wouldn't take D. Okay, yeah, that's why we would get that off the table. But we're going to go ahead and talk about these remaining codes in this line. Already right here, you're done. Okay, but we're going to take a look here. We have the 51797. This is an add-on code, and it's telling us, hey, use it in conjunction with these two, and that's one of them. But this is for voiding pressure studies, intra-abdominal. That's exactly what we had, intra-abdominal voiding pressure studies. Okay, this one was intra-abdominal. All right, don't get it. You could kind of throw you got to be forensic. This one was with the CMG. We had voiding pressure studies, but then we also had voiding pressure studies intra-abdominally. That's why we need that code. All right, and then what about our last code, 51741, complex urofluorometry. Complex urofluorometry. That's why we need that one there. All right, and we've got the 51, okay, because it's indicating that we've had multiple procedures going on. All right, that's why we have that one. And I know some of you might be saying, well, hey, what about that one right there, that 51797? Why didn't we put the 51 modifier on there? Do you guys remember why you would not use a 51 modifier on 51797? That's right, Geetha. Anybody else see that? We do not add a 51 modifier to that to a add-on code. All right, so don't take the bait on that. They're trying to be sneaky. All right, that's how we got to where we did with this particular one. Okay, how we feeling, coders? I know you guys are like, okay, Mr. Tamika, you aggravate me sometimes with these things. You aggravate me. But hey, I want you guys to be prepared. So anything that you see, it is about concepts for me whenever I'm coding and whenever I'm learning something that has to do with the code, because I want you to be able to take this and apply it even when the scenario is different, okay? If you need to get a screenshot, go ahead and grab that thing before we get out of here, because I don't want to get booted out of here. All right. So just remember, guys, when you are going along, okay, remember you want to chun, okay, particularly in this particular area. It's going to help distinguish that one code from another to avoid your mistakes, refine your keyword concepts, okay? You want to only highlight those things that are relevant to your coding to avoid really flowery words, just very, very succinct at the code level, okay? And that'll just cause you to take a closer look. And remember, those parenthetical guidelines, they are supreme. They're like your checks and balances. And yeah, you know that medical terminology is going to help round you out. All right. You guys are the best. I appreciate you guys. Thank you so much for participating with me on Saturdays, for really sacrificing your Saturday time. I hope that it is worth the investment. I do my best to make it worth it. Okay. Hey, leave us a comment. Let us know what we can continue to do to help facilitate your learning. I hope that your weekend is a great one. All right. You guys have a beautiful day. Miss Andrea already stepped out. She had some things to do, but hey, she hung with me to the very, very end. All right. So you guys enjoy. All right. And I appreciate you again so very much. And we will see you again on the next Saturday study session. All right. Have a great one, guys.